Hello class, we've come to the point where we're going to discuss the special patient populations. And of course that means our geriatric population and our pediatric population. As you know, in the laboratory, most of our reference ranges are geared towards those of us who are in the 18 to 50 age bracket, and we have to make different ranges for those who are below 18 and those who are above 50. So we have special categories created for those populations of patients, and we will go through them in this presentation. The first group that we're going to talk about are the geriatric patients. One of the things we have to be mindful of with geriatrics is the current demographics of the geriatric population. In the United States, we get this information from the United States Census Bureau, and the data that we have is from the U.S. Census Bureau printout regarding the year 2010 through 2050. So the U.S. is expected to experience growth in the older population. That's because our baby boomers have gotten older, and with our advancements in healthcare and preventive care, we see people living longer. So now they're living towards the 78 range of age, whereas before they were dying in their 50s and 60s at one point. So dealing with that as our premise, we have to now change how we look at laboratory medicine. In 2050, the number of Americans aged 65 and older is projected to be 88.5 million. That's quite a few people, and that's supposed to be more than double what was projected in 2010. Now we're in 2018, and we know that that number is on the rise steadily. For those of us living in Florida, we see it every day. Remember, driving on the highway. So what does this mean for a laboratorian? Well, it means that we have a situation whereby chronic disease increase. Anytime you have chronic disease increase, you will see a change in our ranges. What becomes normal now or more acceptable for that age bracket. Some tests related to kidney function might be the norm for them, whereas it is not the norm for younger individuals, and we will discuss that as we get further into this presentation. More laboratory tests are being ordered. What we see in Florida is these individuals come from up north and they come with good insurance. So they go to the doctor on a regular basis, and therefore we have to order more labs to see what's going on with those individuals. If they have certain disorders, those labs can be ordered as frequently as once a week, sometimes twice a week. At least every 3 months, we're seeing laboratory tests being ordered on the elderly population here in Florida. Next thing we have to do is adjust our reference ranges. Most of the time in labs, and I was a lab director, I can tell you that we have separated ranges. So we have a range that is acceptable for our pediatric population, a range that is acceptable for our children, a range that is acceptable for up to the adolescent stage, and a range that is acceptable for what we consider the normal adult population, at least to about the age of 50, 55. And then we have a range established for our geriatric population, those greater than 55, pretty much greater than 65. So you'll see that that change is going to continue to take place as people live longer. So why do we see changes in the geriatric population? What changes, what causes them to be in a different state than what we are? Well, as we've discussed in most of our other classes, that's just a natural part of aging. There's a little thing called homeostasis. Homeostasis is when normal aging decreases the body's ability to withstand stress and challenges as homeostatic mechanisms decline over time. So your coagulation, remember I've talked about that in our hematology class, for those who've been through the hematology class, the fact that there's a balance that exists between bleeding and clotting. That system is thrown off as we age, just by the normal wear and tear of the body. The other thing that we have to consider is there's a physiological reserve. Our body is such a unique tool or instrument that it does have some built-in reserves because it knows we are going to age at a certain point. So it has a little bit of extra in it to where although you're getting older, that organ is able to continue with the physical activity level that you need for functioning. Although it's decreased, it's sometimes decreased because you're older or because of disease state, but it still exists just at a weaker level. So in the geriatric population, which systems are we seeing being impacted by aging? Well, the kidneys, the bone, muscle, sarcopenia, endocrine system, immune system, gastrointestinal system. Those systems just have a normal wear and tear that occurs with them. Of course, we know other systems can be impacted with aging, but it's not just about aging, it's about lifestyle. And we have discussed some of those in previous sections, and the liver, the heart, and things of that nature. About the kidneys. Okay, one of the things that happens in the kidneys regarding the geriatric patients is that kidney tissue decreases. What this means is the number of nephrons decrease, and if we remember from our kidney chapter, the nephrons are the functional unit of the kidneys. So when the number of nephrons decrease, then it becomes obvious that the kidneys will not be able to function as well. Another thing that occurs is blood vessels supplying the kidneys become hardened, causing the kidneys to filter blood more slowly. This leads to a decrease in glomerular filtration rate and a decrease in the concentrating capacity of the kidneys. What are the laboratory tests that we normally use for kidney assessment? Well, most of the time it's BUN and creatinine. However, we got a little issue with BUN and creatinine because the creatinine is not the same for the elderly. The creatinine is different for elderly because elderly have a reduction in their muscle mass. Elderly aren't bodybuilders. They aren't outside working and lifting weights, unless it was Jack LaLanne. So when we run the creatinine for the elderly person, it's going to be lower normally, which could give a false indication that there's actually a problem going on with the kidneys when it isn't. So it is better for us to use the glomerular filtration rate, and then that's of course going to be using the Cockcraft, GALT, or the modification of diet and renal disease formulas. Those are the formulas we talked about in the kidney section regarding using the urine, the plasma, and the body surface area of the patient. So you actually have to correct for how much the patient weighs with these different calculations. So we're going to move on to the bone. The bone is important because one of the things, if you think about the elderly, you always think about elderly falling and having fractures, hip fractures, and things of that nature. And this is because the remodeling process from bones that we do when you're young is kind of impaired, it diminishes. And what this means is that there's a process where we remove old bone and replace it with new bone. So osteoblast is the building of new bone, so that's bone formation. That balance is thrown off. So what we have happening is that the bone remodeling units are not the same, and therefore we don't make as much bone as we should while we're still removing bone. So we're not reabsorbing bone as well. So the goal is to maintain bone mass and strength to resist deformity. How can the elderly do that? Well, one of the ways they can do that is by lifting weights because increased muscle mass helps. And another thing that they could do is making sure they have enough calcium in their diet, which is needed for the bone remodeling process. Bone loss with age is normal. Bone mass peaks between 25 and 30 years of age and then declines. And our geriatric patients, of course, are up there 65 to 85, so they've had 30 or more years of bone declining. So what are some of the challenges regarding the bone? Couple of challenges exist in that there's increased bone resorption, which means the bone density is lower, and then there's decrease in the formation of bone, that osteoblastic activity. So we're not making as much bone, which happens and allows you to recover when you fall, and the bone is not as thick. See, when you fall when you're younger, the bone is thick and you're able to absorb it and the bones don't break. When the bones are thinner, they're not as thick, then of course you have fractures occurring. Why does this happen? Well, it happens because there's a shift from osteoblastogenesis, which is the making of bone, to adipogenesis, which is adding fat in the bone marrow. So calcium absorption and transport in the intestinal mucosa are definitely decreased. Renal function is has an issue because the conversion of 25-hydroxy to 1,25-hydroxy changes, and then this leads to a decreased calcium absorption. Peak bone mass depends on the diet, so how much calcium is the individual taking in, and then other things. Are they physically active? How much do they weigh? Are they obese? Does the person lift weights? Are their thyroids functioning? That's what the endocrine activity means. Gender, because males have less fat than women. So then the genetic makeup, because there's some people who are more prone to actually having bone challenges based on wherever they come from. Bone challenges continue. We're going to talk about osteoporosis briefly. What you need to know is that osteoporosis is deterioration in bone mass and microarchitecture. So then the patient ends up having more fragile bones. And what we see normally is a person comes in with a fall and they have a hip fracture or a vertebral fracture with very minimal trauma. I told my students earlier that I once used to do things like I was a tomboy. I would jump out of trees and things of that nature, but there's no way I would do that now because my bones are not as strong. They couldn't handle it. Osteomalacia. Osteomalacia is a vitamin D deficiency in adults that results in a shortage or loss of calcium, causing bones to become increasingly soft, flexible, brittle, and deformed. And then osteopenia, which is a decrease in bone mineral density, which precedes osteoporosis. Conditions related to age, related bone loss, secondary hyperparathyroidism, gonadal sex steroid deficiency, obesity, increased serotonin, peak bone mass, corticosteroid usage, malabsorption, smoking, and inactivity. One of the interesting things about this list is that some of these things go together, meaning when you're inactive, you increase your obesity, okay? When you're inactive, then your bone mass is already going down. So once you do become active, you're at greater risk for falls. So some of it kind of goes together. So what are the laboratory tests that we can do and help with defining what some different conditions are? So with osteomalacia, that's our first one. We see hypocalcemia, so decreased calcium and decreased phosphorus, hypophosphatemia. And vitamin D deficiency, we see a malabsorption due to poor diet, so calcium is decreased, phosphorus is greatly decreased, and alkaline phosphatase is increased. Osteocalcin, which is also bone glycoprotein 1A, is increased. So those are some key tests that we can use to differentiate those two disorders. The next one is primary osteoporosis. Primary osteoporosis shows normality of calcium, phosphorus, and alkaline phosphatase. Additional bone laboratory tests. So calcium absorption. Calcium absorption and metabolism is affected by decreased magnesium. So calcium goes hand in hand with magnesium. We have biochemical markers that we could use to determine if their osteoblasts are being produced or if osteoclast products. So what you should remember is that the osteoblast products are the BSAP, OC, PICP, and PINP, but the osteoclast products are urine tests, hydroxyproline, free and total prednisones, and teleopeptide of collagen cross links. So that's what you should take away from this slide. Okay, at this point, there's some information that I would like for you to take the moment to read, and I'm going to give you a few minutes to do so. The laboratory biomarkers for sarcopenia are inflammatory biomarkers. Remember that C-reactive protein is one of the key indicators of inflammation. Doesn't necessarily mean that a person has a specific disorder because C-reactive protein is very nonspecific. But then if you combine that with interleukin 6 or tumor necrosis factor alpha, then you can kind of have an indicator that you might have sarcopenia. The next system that we'll briefly go over is the endocrine system. Remember, we're dealing with the geriatric patients. And in life, you have one thing that happens when a person is born. Most of the organs are not functioning to their greatest capacity. As the person matures, the organs reach a state where it's peak function, and then the organ normally stops functioning as well. The endocrine system follows a similar pattern. Three things can happen to hormones. Some decrease. Aldosterone, growth hormone, and renin are examples. So with age, that means your aldosterone levels decrease, your growth hormone decreases, your renin decreases. The other thing that happens to hormones is that some of them remain the same or slightly decrease, meaning it's just at the lower end of normal. An example of these are cortisol, epinephrine, insulin, and thyroid hormones. Another thing that can happen is that some hormones increase. Examples are FSH, luteinizing hormone, norepinephrine, and parathyroid. So continuing with the endocrine system, one of the things that we notice in thyroid function changes that TSH increases even if the person doesn't really have a known thyroid issue. Free T4, it stays the same. In males, we see a decrease in free T4, but not the TSH. So this is one way we can differentiate what's happening in the male from what's happening in the female, because in females, the free T4 is normal, but the TSH normally increase. I created this chart for you as a way for you to memorize some of the things that you can see happening. So we're going to use TSH as one test and free T4 as the second test. If the person has overt hypothyroidism, that is decreased hypothyroid, hypo is low for thyroidism, TSH will be increased, free T4 will be decreased. When a person has subclinical hypothyroidism, you see the TSH increase and the free T4 is normal. Then when a person has subclinical hyperthyroidism, you see the TSH is decreased and the free T4 is normal. One of the things that you can pay attention to is that the TSH is elevated in cases of hypothyroidism, and the TSH is decreased in cases of hyperthyroidism. So that's the relationship with TSH is quite the opposite. So hyper, if you have an increased thyroid, then your TSH is decreased. If you have a decreased thyroid, then your TSH is increased. Okay, so what are some additional endocrine labs that we do? Well, PTH, parathyroid hormone. In the elderly, we see it increase because renal function is not the same and calcium absorption is decreased. Epinephrine can be normal or decreased, and norepinephrine is increased. The serum cortisol and adrenocorticotropic hormone do not change, but aldosterone and renin can be decreased. And this can lead to what's called orthostatic hypotension. The orthostatic means standing, like when a person is still. So this together means that the blood pressure is decreased upon standing. Additional labs, growth hormone. Growth hormone is decreased, and it is associated with decreased insulin-like growth factor. Somatopause is considered decrease in growth hormone secretion. Insulin decrease. Of course, insulin decrease is prevalent in type 2 diabetes. So 20% of the individuals greater than 65 have type 2 diabetes. Menopause, ovulation decreases, and of course you have estrogen decrease, follicle stimulated hormone decrease, but luteinizing hormone is unchanged. And then we have andropause, I call it male menopause. testosterone and DHEA levels, along with pregnenolone, are decreased. Your LH and FSH are increased. Finally, we have melatonin. Decreased melatonin leads to insomnia. So what happens to the immune system for the elderly? Well, of course, the immune system has kind of worn out a little bit, so immune function declines and the patient becomes at a greater risk for infections. The patient produces more autoantibodies. You see more rheumatoid arthritis and autoimmune disorders. You see lymphoproliferative disorders and different types of cancers and things of that nature. Greater morbidity and mortality. Now we have the gastrointestinal system. The gastrointestinal system is not impacted the same way as the other organs due to aging. However, because of some other conditions, we end up having the elderly develop a couple of things. One, diverticulosis, and two, digestive tract disorders. Some of this is because the elderly are not eating appropriately. They have those malabsorption issues. It's not really about the GI system itself. And achlorhydria is the absence of free hydrochloric acid in stomach, which of course can cause an issue with more bacteria being grown. Vitamin B12 deficiency can occur, decreased iron absorption and decreased calcium absorption can occur. In the elderly, we have a couple of things that happen. Chemistry analytes can either go up, stay the same, or go down. This is a list of things that can increase with aging. GGT, liver enzyme, gamma glutamate transferase. Alkaline phosphatase increases in women. Alpha-1 antitrypsin, amylase, AST. Now remember, amylase is a pancreatic enzyme, AST another liver enzyme, BUN for the kidneys, CK for the heart. The gamma globulins, your immune gamma globulins. Fasting glucose level can increase as well. HDL, inorganic phosphate, lactodehydrogenase, potassium, bicarb, total cholesterol, triglycerides. Some of the things that can decrease: albumin, aldosterone, bilirubin, creatinine clearance, and PO2, total protein. The analytes that remain unchanged: chloride, haptoglobin, insulin, the fasting insulin, pH, or sometimes you have a slight decrease. So what are the things we have to watch out for with geriatric patients and pre-analytical variables? Well, some things we have to look out for is the age, the sex, the time of day, the season, the altitude. You know, if a person is in Denver and they have labs done and that individual comes down here to Florida, then of course their lab values are going to be different. One, they're at a different altitude. You have your PO2, you have your respiration rate changes. And then also you have different instruments, so that's a little thing we have to deal with. Lifestyle, diet, alcohol consumption, and smoking, caffeine, physical activity, all play a part in the variables associated with laboratory testing for geriatric patients. Specimen collection, one problem we have is hemolysis. A lot of times the geriatric patients have that kind of thin skin, and some people have trouble collecting the blood, or they have trouble getting the appropriate volume. There's other things, medication, because of course we know medication, if you're on cancer medication, then definitely your labs are going to be different than they would be if you were not. If an elderly person is on anticoagulants, the same thing exists. And then antibodies that the person. Our next special patient population is the pediatrics. Pediatrics includes infants. The definition of an infant is a newborn in their first 28 days of life. The next part of pediatrics include a child or children. A child is the first 5 years of life, and in that time we see physical growth and increased complexity of functioning As a matter of fact, this is the most growth that the child will experience. Birth weight triples and brain size increases. The third category is our adolescents. These are teenagers. So it's rapid physical, cognitive, emotional, and social development. Starts at between age 11 and 12 actually, and ends between age 18 and 21. Now, the side note is that the body is normally more mature between age 16 and 18. However, the mind doesn't necessarily catch up. So a person can physically have a baby, deliver a baby, carry it to term, and not actually be mature enough to do what it takes to raise a baby. So there are some reference interval challenges with pediatric samples. One of the problems is that the phlebotomist may not be able to collect enough sample. That's one of the same thing that exists with geriatric patients. Another problem is the analyzer might not be able to run the small sample size because analyzers have what's called dead space. There's a little portion of it when the needle goes into a sample well, it doesn't actually go all the way to the bottom. So if the sample isn't down in the bottom of the well correctly, then you may not actually get a good sample and therefore get inaccurate results. Okay, due to small patient population, we really have a hard time establishing reference ranges. And one of the solutions for this is that CLIA allows us to use established reference ranges from manufacturers. Another solution to these issues is to use point-of-care analyzers because point-of-care analyzers can take smaller volumes. Okay, this chart represents examples of pediatric reference intervals. In the section that says creatinine, you see this section here where it says creatinine. Six, 7, and 8 are reference sources, and then the time is here, and it says time means how old the person is. So between 1 and 11 years of age. If we use the analyzer, which is the VITROS 5600, the reference range would be 0.23 to 0.61 for males and 0.23 to 0.61 for females. Another source that was used shows that for persons aged up to 5, the analyzer didn't tell us what it was, but the reference range is 0.5 to upper reference level. That's kind of not clear. But this shows what you get from package inserts when it comes to pediatric samples. And it makes it kind of difficult for a laboratory to establish what a range should be. Glucose has some similar issues, but if you notice the glucose, we have things like 0 to 30 days. VITROS 5600 is 40 to 80. But then a full-term newborn, the analyzer is not listed, but the range is 20 to 110. So that's a difference. That's a huge difference. A person greater than 7 days, reference range would be 54 to 117. So what are some of the things that you have to consider with specimen collection? One, the size of the patient and total blood volume, communication with patient, emotional behavior of the patient. Although you may have a patient that is, say, 10 years old, that person could have the IQ of a 5-year-old, and they're going to act out and maybe not respond to you the way you think they should. Another issue is that communication with the patient and family members, because when we're drawing a patient, a pediatric patient, we need the family member's help. And you have to be clear about telling the family member how to hold the patient so that you can actually get the best sample without the patient moving. Some of these other ones, I'll give you a few minutes to read. Now, there is a difference between a capillary sample and a venous sample. There are some values where the capillary value is greater than the venous value. Glucose is an example. It is 1.4% higher in a capillary sample than in a venous sample. Potassium is 0.9% higher in a capillary sample than a venous sample. There are a few analytes where there's no difference between samples. Phosphorus and urea are two examples. And then there's those samples where the capillary value is less than the venous value. Okay, this is a chart that just shows recommended blood draw volumes for pediatric patients. The one thing I want you to take away is that the weight is, say, 2 kilograms, and the maximum volume of a draw is like 4 milliliters. This is very important because we can't run every test on each pediatric patient. We have to spread it out through the day. And we have to be mindful of how much blood is taken from the patient throughout the entire day. I worked at a neonatal, actually it was a women's and children's hospital, and so we used to have things, a little chart that tells us how many times the patient could be stuck in a day and how much total volume could be taken from the patient, because we do not wish for the patient to become anemic, and we do not wish to put the patient in a situation where they actually have to have a blood transfusion. So here's just a list of some of the pediatric point of care tests that can be done. And that one should be glycose is glucose. One of the biggest issues with pediatric patients is respiratory disorders. More than 50% of deaths in children younger than age 1 and about 20% of all hospitalizations of children under 15 are due to pulmonary diseases. So that's a pretty large number. Two of the issues we have is acidosis and alkalosis. Of course, acidosis is the low pH, alkalosis is the high pH. Another issue that we have is cystic fibrosis. And then the CFTR is a gene mutation analysis that's associated with cystic fibrosis. And then we have lung disease, gastrointestinal disease, and sweat collection is one of the things that we associate with cystic fibrosis as well. The regulation of blood gases and pH depends heavily on the patient's lungs and kidneys being mature enough to regulate the acid-base metabolism. So therefore, in the history of my time in the laboratory, we had a couple of things that we did. We had to look for the maturity of the surfactant system in order to determine if the person had respiratory distress syndrome. RDS means there's failure to excrete carbon dioxide, so CO2 rises, causing respiratory acidosis. So the test that we did to assess respiratory distress was fetal lung maturity. We would do the lectin-sphingomyelin ratio, which predicts the fetal lung maturity, and a ratio of less than 1.5 is indicative of surfactant deficiency. The test is invasive because we actually have to do some intrauterine procedure to get this sample from the mom, from the baby. So nowadays they use fetal fibronectin, abbreviated lowercase f, capital N. So this test is used to determine the likelihood of premature delivery and the risk for fetal maturity in women at high risk for preterm delivery. Those women who are over 40 and 50, you know, Janet Jackson of the world, who like to have babies after 50. So fetal fibronectin is a protein secreted by the fetus. So towards term, it is found in maternal cervical fluid. And this means that we can actually get it from the cervical fluid of the mother, which is less invasive. A negative test has a high predictive value that preterm delivery of the baby is unlikely, and a positive test is moderately predictive. Causes of acidosis and alkalosis in neonates and infants include respiratory acidosis, hypoventilation, metabolic acidosis, renal tubular bicarbonate wasting. Respiratory alkalosis, continuing on, high blood ammonia, metabolic disease, metabolic alkalosis, pyloric stenosis, excessive bicarbonate. Okay, cystic fibrosis. Cystic fibrosis is common here in the United States. So it's a genetic disorder and it results from inherited mutations in the cystic fibrosis transmembrane regulator. That's the CFTR gene. So you will need to associate cystic fibrosis with the CFTR gene. The patients can have pancreatic insufficiency, steatorrhea, and failure to thrive. Another thing that occurs is they have Pseudomonas infections, and cystic fibrosis is considered untreatable. So how do we test for it? Well, there's two ways. One way is sweat chloride, and I actually have performed this test. So the sweat content is measured after pilocarpine iontophoresis, which means we put a little disc on the patient, and we have to, one, you got to get the patient to be still to get the disc on the patient. And then they go home, they go wherever, and then they are allowed to sweat in kind of a natural environment. And then they come back and you collect that sample, and the sweat cannot be measured by a normal analyzer, so you have to put it on a special chloride meter in order to measure it. So this was kind of difficult because, babies don't cooperate. They don't really know that they need to keep the disc on, and moms sometimes don't really follow that either. So the next thing that we can do is DNA analysis of CFTR. The most common mutation is delta F508, so we can identify that mutation in greater than 90% of the patients who have cystic fibrosis. In order for a person to have cystic fibrosis, he or she has to have 2 abnormal copies or mutations of the cystic fibrosis gene. An individual with 1 mutation will be considered a carrier. So how do we interpret sweat tests? You do need to know this for your exams, just to be able to understand what it looks like. Next section we have is the liver and pancreas disorders. One of the key things to pay attention to is jaundice, which is yellow discoloration of the skin, the sclera, and the mucous membranes due to excessive bilirubin in the blood. It appears when a total bilirubin level is 4 to 5 in infants, but older children can have it be when it's greater than 2. So this slide represents the liver function test that we do in the laboratory. Okay, acute pancreatitis. Remember what I always tell you, that when something is acute, the body kind of, really overreacts and things tend to be out of sorts. And then as it becomes chronic, the body kind of recovers. So I'm going to give you a few moments to go through this slide. One of the things that you pay attention to is lab findings. You have increased amylase or lipase, more than 3 times normal. Elevated lipase lasts longer than the elevated amylase. And infants less than 6 months may not have elevated lipase or amylase. Therefore, we have to use the immunoreactive trypsinogen to test those patients. And just like with the elderly, we have endocrine disorders that occur. Endocrine disorders are fetal thyroid development. So fetal thyroid develops as early as 10 weeks, but by the 11th week, you have detectable amounts of thyroid hormone. One of the things to remember is that the TSH kind of does this surge right after birth. So we don't normally draw TSH levels on the first day of birth, because if we do, it's going to be elevated. But don't worry, the TSH will return to normal within a few weeks. Within diabetes, remember type 1 used to be called juvenile diabetes. This is the most prevalent type of diabetes in people under 20. Type 2 is most often diagnosed with those over 40. However, we're seeing more cases diagnosed in the United States because we have a problem with obesity. Okay, this is key. To be diagnosed with diabetes, you have to have one of the following criteria. Fasting plasma glucose level greater than 126, plasma glucose level greater than 200, glycated hemoglobin, hemoglobin A1C greater than 6.5. And if you have one of those, you have to repeat it and make sure it occurs again before you can say that the person actually has diabetes. Another section that we deal with babies is inborn errors of metabolism. So these are disorders in which a single gene defects cause clinically significant blocks in metabolic pathways. The OMIN provides detailed information about the inborn errors, and it has a system where they actually give a 6-digit code to each disorder and then tells you what the disorder is. Okay, this inherited metabolic disorders chart is just an example of some of the things. I left off the OMIN number just so that you could pay attention to the disorders, such as maple syrup urine disease. It tells you the enzyme defect, keto acid dehydrogenase, and then it tells you the clinical findings, hypotonia, and a coma, and then it tells you the biochemical markers. The biochemical markers are the ones that we would actually be testing for. Pay attention to the last point that the testing for newborn screening is done by tandem mass spectrometry. Okay, disorders associated with nutrition are impacted by a few things. One, growth rate. In infancy, you're growing faster than any other time. Body composition, and then the composition of new growth, like how much protein does the patient have. The chart on the right is showing that if a patient is premature, we can have a deficiency of all vitamins, versus if a patient has fat absorption syndromes, we would see a deficiency of vitamins A, D, and K, because those are the fat soluble vitamins. Okay, toxic substances in the labs and how to detect them. Acetaminophen, of course, on the right hand side, we see the lab test that we use. SC means as a send out. DAU is a drug abuse on the urine. So acetaminophen, we see that that's serum acetaminophen, and LFTs for liver function test. And this concludes the section on special patient population.